Each candidate is expected to do at least 5 hands-on cases at different levels, depending upon the prior experience, and throughout the course. In the meantime, we will have continuous lectures in between. We will try to engage you as much as possible, inshallah, and hopefully it should be a very interactive session. Most of you are pretty experienced and already doing EUS with strong CVs, we heard. So inshallah, it will be a very nice session with all of you. Right.
And don't worry about taking notes or anything. You can access these lectures. The Facebook link is a very good link. Our AV is very good. So you'll be able to access these lectures as if you're sitting here. So take your time, focus, ask as many questions as you want, and you can refer back to all the material online. So thank you. It's so good to see you, Dr. Miller. Testing. So we're joined by Dr. Saad Khalid Niaz, our mentor and the head of the institute. So I would like to call him on stage for a few words regarding the course.
Okay, Bismillahirrahmanirrahim. Apologies. I think the signal outside Civil Hospital broke down. So once the signal goes, there was a complete gridlock just outside the hospital. Anyway, so I didn't realize this is the 6th EUS course. Time flies. SIAG, for those who, most of you already know us, we have 3 objectives. And that's what led us to develop this institute. The first one was service. Service of hopefully the highest quality and free of cost. In the service, we had 3 things in our mind. I'm sharing this because I think you're all young, and hopefully, inshallah, one day you'll have the same opportunity, and maybe you'll share the same goal, and it would make it easy for you to achieve. So the 3 things in service was, one, that because we are providing service free of cost, it should not look different to any private hospital in any way. That was ambience. The second thing was that we should not compromise on any equipment. And so I'm humbled, alhamdulillah, that we're the only institute in this country to have the kind of facility under one roof that we have here, starting from fluoroscopic procedures all the way to ESWL. Everything is done in our unit. And we are very fortunate to have pH, motility, service again, free of cost. Things like FibroScan, ultrasound, everything is so. And we haven't compromised it. The second thing was equipment. We didn't want to compromise on our equipment. So the equipment we have is at par with any international center. The third thing was the attitude of the staff. And I think it's very important for us to understand that those who come to our center are doing a favor to us. We are not the ones who are doing favor. And that has to go and be put in everybody's mind. Patients provide you as physicians, doctors, surgeons, whatever. Allah uses them as your providers. So unfortunately, whether we like it or not, it's not us who's doing a favor. It's them who's doing a favor. And in our institute particularly, because this by and large is a cashless facility, And most of our patients come from lower socioeconomic background. We don't want them to feel that, you know what, there's a special place for you. There's a special place for those who can afford, those who have all the amenities that Allah has granted them, versus those who don't. I mean, I think the principle in education and health we need to learn from other countries, and that should be a universal thing. It is a universal right of every citizen to have the best quality of health and education. Unfortunately, we lag behind by miles. So those are the three aims in service provision. The second thing was to be involved in training. And that's why you're all here. We have training in-house for those who are our fellows, our research fellows. And we also did short fellowships, but the requests have now become so many, that it's really difficult for us to focus on our own faculty, on our fellows. And obviously our priority is our fellows. So message here is that for some time we are not going to have any short fellowships until I'm happy with what we have committed to our fellows. So this in-house training, we have these courses. This is the 6th endoscopic ultrasound. We've done 8 ERCP courses. We finished the 8th yesterday. And that's why I think I'm a bit tired, because this is the first time we're actually going all 6 days. In fact, not 6 days. It's going to continue till Tuesday with the next bariatric endoscopy thing. So training, we thought, how can we contribute to people who are not here in Karachi or who are not in our institute? And that's where this course came about. You all know, some of you have already attended the courses, that we started these way back in 2010 with colonoscopy. And I'm very grateful to Dr. Waqar, Paul Hagan, and then Khalid Hassan, who will be joining us shortly, and Mustafa Rai and Nadeem Tehami, and we had Sri Shahabar last year for ERCP from UK, and local national mentors, faculty, Professor Riyasul Nabi Tayyab, and for some time even Amjad Salamat Saab had come. So this program is actually not for you to come see us do it and learn. This is about giving you the scope in your hands, teaching you the maneuvers that you need to do, whatever the course is about for this. This is obviously EUS. And this is the only thing that I will confess that I wasn't trained when I came back from UK, because EUS in those days was very early and very boring. It was just a radial thing, and they used to take almost sometimes an hour to do just, and you start looking at gray. And the fear you all have, and I'm sure I had when I started, from the real thing, the red color, I call the beautiful pictures of the intestines or stomach or colon, to this black and white, which we are not used to. And so I took the wrong way. I started trying to understand what the gray was. Very soon I realized that you really don't need to. I used to think I spend more time in learning EUS than anything that I know. And I think a lot of that time I wasted. And partly because I think the way EUS is projected is that this is really difficult. Because how will I understand these structures? They all look the same. But it's actually the easiest procedure that I do, honestly. Because there are only really 6 things you can see practically. If you take the submucosal lesions, what can you see? You go from the esophagus, you've got, 2 spaces, one mostly not useful, which is the AP window, and that worries most of the juniors, and it's very easy to see. Then you have the, subcarina. Then you come down to stomach. What are you going to see in the stomach? We have fixed things that we see. So you will see from one end, from the pancreas all the way to the spleen. In between, you'll see the kidney. We get very excited when we see the adrenal. Most of the time it doesn't, it's not really helpful. The aorta, celiac artery coming out, all that in the stomach. Pictures become very easy. Hopefully by the time you'll be done in the next 3 days, you will be familiar with all this. The third place is duodenum. And if you divide that into two, that's what I do. Bulb, you see the head of the pancreas, you see the portal vein, you see the CBD, pancreatic duct. And then you go to D2, and you can see the uncinate. And that again is very simple. For those who are doing ERCP, reduction of the scope, and it's all done. We will demonstrate you everything that I'm talking about in great detail in the next 3 days. So hopefully by the time you go, this great thing should be out of your mind. You'll be able to recognize everything, inshallah. We've also, for the first time, created models for you so that you can actually use and puncture a cyst, okay, and have that feel of how do you use the needles and biopsy, rather than doing it on the patient. So you have plenty of time. You can. So that's something that we are adding. That model was made here in our own institute. So hopefully we'll have a feedback from you as to how good it was. So with that introduction, the last thing we did was an R&D department. We're a very small R&D department. There was only actually the whole department plus 2 people. And in that R&D department, we've developed your models for ERCP, which some of you have used for the ERCP course. We are actually improving that. Then you have colonoscopy, polypectomy models. Now this EUS model. We're still working on getting diagnostic EUS model as well, which hopefully we should have before the next course, inshallah. Alongside that, something that and we are only 2 years old in this institute. A lot of us, when we were in COVID time, we had shortage of PEG, we had shortage of a lot of accessories. And that prompted, me to think, what's so special about these accessories? Why can't we make them? The simple ones, the low-hanging fruits. So we are also working on developing accessories. So savory wire, PEG, and now we're working on an EUS needle, EUS FNB needle. And we have the EUS needle, that's not a problem. So the prices have gone down in our initial, when we've created these, have gone down to as low as 10%. And if we can do it, I'm sure everybody can do it. So that was an introduction. We are very fortunate, let me tell you, along with that, for the patient safety and quality, we are very lucky to have a very strong anesthesia support led by Professor Safia. She's here, and we'll obviously hear from her as how she supports us. Starting, what we generally do is, and I was hoping that our faculty will be here, is that we want to know, Abir, can you do the start, please? Yeah. So what we want to know is from the hands-on people, where they're from, have they done any EUS or not? Have they got the facility to do EUS? And what are the real expectations that you've come here for? And if you're doing EUS, what are the problems you're facing? Welcome, Arif Siddiqui. Dr. Arif Siddiqui is a faculty here. And for the observers, I know what you're going to write in the feedback. Observers should have some hands-on experience. Unfortunately, that's just not possible. Our focus is the hands-on guys, and that's why we restrict it to 5 people, because it should be really, we want you to try and teach everything that we've learned or we know. And you have some of the best people here who do EUS. So we start with Dr. Junaid Mushtaq from Lahore, I know that. Junaid, just tell us, the questions that I've asked. So I would like all the. Bata.
Thank you very much, Dr. Saad, for giving me this opportunity. Participant as a hands-on course of EUS. So there are a couple of things that I would like to improve while doing in EUS is number one is the D1. That is the most difficult area where I think the maneuvering is a little bit difficult to find where I need to start and how do I need to go around that area. And number two is tracing the PD at GE junction, like when you are in the proximal stomach. So these are two areas that I find most difficult to maneuver around.
So the D1 and tracing the pancreas from the stomach of pancreatic duct. While I was talking, I mean, you can actually trace from the stomach. You can also see the CBD literally up to the patella as well if you want to. Do you really need to in everybody? I'm not sure. You need to look at the organ. You see a lot of videos coming out. You see a lot of things coming out. But yeah, I take a step back and I say, how is it going to help my patient or what I do? And a lot of times, looking at the thyroid, yes, you can look at the thyroid, but is this my job? No, it's not. So I'm personally, I'm not saying it's wrong, but I'm not interested. I'm interested in what actually helps my patient and my practice. And that's what makes EUS simple. Because you can trace every artery or every vessel. But my question, a lot of times, even in the international, is what have we achieved? Yes, we know. But what are we doing? Are we actually looking at GI, liver disease, or spending as a radiologist? We're not radiologists. So, good. When you do, when you're in the bulb, what maneuver do you do to try and get the whale sign or the portal vein, or what do you do exactly at the moment? What do you do, which is causing you difficulty?
So the most difficult thing is to what I've learned is like to get into the duodenal bulb and bring your big wheel down and suck all the air and slightly like clockwise and anti-clockwise rotation and
Down meaning away.
no towards you to big wheel, yeah big
So
wheel,
you want to go up and
Yeah.
a little bit anti-clockwise.
anti-clockwise, yeah.
Sometimes what happens is you don't have to do anti-clockwise.
Yeah.
Sometimes you first look at it and then gradually do anti-clockwise. Sometimes you can just do anti-clockwise.
Yeah.
Khalid? No, so D1 से fallback नहीं होना.
नहीं होना चाहिए.
That will only happen if you have a root. Going to the stomach, when you are just entering, you stop there. क्योंकि वो बना हुआ है ना, वो आपको होल्ड करता है. अगर आपने movements इस तरह की की कि you are going towards the duodenum, then obviously you go either backwards or over. If you just go in as you enter, you just lift it up, which is bringing your big knee towards you, and just a little bit of
Anti-clockwise, yeah.
I just wanted to know, okay,
Yeah.
so I can, we can have it here, and hopefully by the time we finish, we'll have a look at it and see whether we have achieved it or not.
Yeah.
Great. Have you done any FNAs, FNBs?
Yeah.
Or you have?
Yeah.
Okay. Right. Anything else you want to say, Junaid?
No, that's good for now.
We had to get together for something, and it's my fault. He had asked me some.
Yeah, definitely.
We need to sit down and talk about it. Najmus Seher.
Assalamualaikum. I am Najmus Seher Saeed. I am actually heading the Department of Gastroenterology Hepatology in newly formed GMC Teaching Hospital, Gujranwala Medical College Teaching Hospital. And you were talking about 24-hour pH, and I was thinking that we have available everything in our department, including 24-hour pH except spyglass, manometry, fibroscan, capsule, enteroscope, everything. So after making the ERCP a routine in my hospital, my next task is actually to make the EUS freely available to the public, inshallah. So I've been doing EUS and I have done FNBs. If I know
How
there
many
is
USs have you done? Sorry.
usually I do 1 or 2 cases per week.
Okay.
Okay.
But how many have you done total? Do you know?
Maybe less than 100.
Okay.
Okay. Uh, I have actually recently done a pseudocyst drainage also, independent and successful one. If I know there is a lesion, I can go in, I can size it and do an FNB. But if I don't know, like I'm doing it for to confirm whether there is something or not, I feel lost. I find it difficult to follow, the vessel and keep it where it is, and the scope position changes, and then I wonder whether I'm at the right place or not. This is what I feel difficult about. Apart from the D1 point Dr. Junaid just mentioned, I hope to improve that, inshallah.
So you did pseudocyst by yourself?
Yeah.
No supervision?
No supervision.
You're a
I
brave,
actually
you're a
tried.
brave lady.
Actually, I tried to get somebody multiple times and I got a very poor response from multiple
Fair enough.
people. So, how long should I wait? I don't know. So,
I
this
think you
situation.
should wait. If you look at the literature, now it's very clear. You need to have a certain number of cases before you attempt therapy. The fact that there's a problem and the fact that there's nobody else to do, you're taking a risk because God forbid if you have a complication, and which can happen because it's not easy to put a plastic stent. Did you put a plastic stent?
I did.
Yeah, the plastic stent placement is even more difficult than lamps, and so alhamdulillah you were lucky you got away. But generally speaking, this is what this is why we have these courses to actually to teach you, to tell you some of the things. This is not a therapeutic course, so I'm afraid you may see an odd case of therapy here if we have something that we need to do urgently, but otherwise we focus on basically diagnostic EUS for you to have the concept first, and then once you are actually able to do that, then you can go ahead and do that as well. But we will give you some experience in cyst drainage. One thing, sorry, आप बोल दे.
Actually, I'm training a Professor Anwar Khan. So I've seen him multiple times draining the cyst without EUS and without fluoro and without. So maybe that's why I.
No, okay. That is an interesting discussion, I'm sure. I welcome Dr. Khalid Hassan, Dr. Mustafa Rai, Dr. Nadeem Tihami, the international faculty we have. I must add that my EUS hair program would not have been here had this young man, Khalid, my little brother, was not here with me. And so that's what I was trying to tell you. I learned EUS not through a program, but through mentorship from someone who is one of the best in the world as far as endoscopy is concerned. And then, as luck would have it, I met another brother who's Mustafa Rai, who again is a fantastic endoscopist, especially EUS and ERCP. So there's a lot of learning that I was fortunate to get from them. And then we have the next generation, a little bit down, Nadeem, who is more known than I'm sure anyone else here. And it just continues. Shanil is part of our faculty. Right, so what we've done is that we've had, Junaid, I want to ask you, how many have you done so far?
So I think I don't have an exact number, but somewhere around,
less than 100 more.
Yeah, somewhere around 100. Like,
okay.
Yeah.
So that becomes, I'm sure, a little easier for us. Okay, Mia Shah Yusuf.
Assalamu alaikum, sir. Thank you for having me. I am Dr. Yusuf from Peshawar. I am heading gastroenterology department at Prime Teaching Hospital, associated with Peshawar Medical College. I am a NAU at US, and as a KP, we all are NAU. We don't have any US service in whole KP. So we were struggling with our patients. We started US service about 6 months back, but we were not doing it. We are calling some faculty and they do the cases from Shifa or from AKU or from somewhere. They do the case and we observe it. Recently, I went to China for a hands-on training at Hangzhou First People Hospital. I remained there for about 1.5 to 2 months. It was a good hands-on experience, but I was struggling with the language. The main barrier was the language, and I came back recently from there. Now I started under supervision of the people who are coming from Shifa to our institute or from Aga Khan. But I am struggling basically with the D1 to how to start there. I just have learned the basic maneuver that scope toward myself, going a little bit anti-clockwise to the 11 o'clock corner and suction and then other. But it's difficulty while tracing that and going that. Just have the theory, but it's difficult. And additionally, I am having a fear of moving from D1 to D2. Always afraid that I may not cause some injury. So that's the basic area where I want to concentrate during this training.
Okay. Fantastic. Nematullah.
I am Dr. Nematullah, District Gastroenterologist, Bajor. Sir, I have recently completed 3 months fellowship in ERCP at Siag, where I have observed a lot of cases, observed US, a lot of cases US, and few hands-on. 4 or 5 cases hands-on. So I am NAI in US and want to learn diagnostic US here. Thank you, sir.
Thank you. Asma Asghar.
Assalamu alaikum, and thank you very much for giving me this opportunity. And I have come from Peshawar, where I work in CMH
We got
as
too
a
many people from
gastroenterologist.
KPK.
And the issue with me is that I am from an institute where all the facilities are focused in few centers, and peripheral centers don't get much of the facilities. So basically, currently I am doing endoscopy, colonoscopy, ERCP, both therapeutic and diagnostic. But the issue is I was trained for US. I did my training in UK, and I came back in 2023, and unfortunately since then I have not done much of the cases because I didn't get a chance. And now I hope to get the facility very soon in our hospital or move to another hospital where there is facility. So I want to overcome the anxiety of having not doing any procedures for such a long time.
Where in UK were you?
Sir, Birmingham Heartlands Hospital.
Heartlands.
Sir, around 200.
You did it by yourself? 200?
Sir, some underscore VN initially, obviously, and in my second half, I stayed there for 2 years. So in the second year, I was able to do independent, including some FNAs, FNBs, and cyst drainages.
So you did independent more than 100 cases?
Yes, sir.
Okay. We'll summarize it for you. We have Dr. Junaid Mushtaq from Lahore, who's done approximately close to 100 cases. His main issue was the bulb and tracing the pancreatic duct all the way from in the stomach. Ajmus Seher, she has done again close to 100 cases. She's from Gujranwala and she heads the department there. And she's done some FNAs, FNBs as well, and she's also trained one pseudocyst independently. And the discussion we were having was she did that first time without any supervision or any other previous experience. Then we have Nematullah, who's seen quite a few ESs. Hopefully grey-black is not that bad, but very few hands-on. And then Asma, who's Mia Shah Yusuf, who's done EUS in China. How many did you do yourself in China? Do they allow you to do it?
Yes, around 50 cases.
50 cases. So now, language ko kaise, how do you, when you're doing a case, how do you?
There were 9 advanced endoscopists in their center. 3 people were doing some English. So I was doing predominantly those. But with other, there was Google Translation. With other, there was a Google Translation, and one fellow was translating my language to them, and it was in between. So.
Okay, so we managed. And last Asma, sir, you've already heard. So Nematullah, yes. So that's where we are. So hopefully we all will have different views, but because I think I was very fortunate to have a fantastic mentor, and we did, after a lot of courses and everything else, doing some cases, we had Khalid over here and we did 70 cases in a week. And that's when he said, "You're good to go now." And I think had that not been the case, then we probably would have struggled here having EUS. Yeah. So the first 70 was with him is like, so I think you have very patient trainers, much more patient than I am, I'll be honest. I'm not a very good teacher, but I learn from them how we teach as well. So with that, we'll start the first talk, amnobology, because one of the first things that scares everybody, and most of the people don't know, is what's there on that little cockpit that we are sitting on. So, Mustafa.
And just okay, so we'll get started. The neurology talk actually I had never done till Dr. Sadmiaz had me come to this course, but I learned a lot from it. And there are a lot of things that we just take for granted in endoscopy and really don't fully understand till we actually start reading about them. And so my first advice to all of you, if you already know this is great, but if you don't, this is not passive information that you just pick up. You actually have to actively seek it, and then you can learn and become better at understanding the principles of ultrasound. And that allows you to actually do better EUS exams. So starting with the principles, you may already know this, but ultrasound obviously means high frequency. It's ultra compared to sound. So sound is in the 20 to 20,000 hertz range, right? If you look at this diagram at the top. Pointer, you will have, right? So 20 to 20,000 hertz. But now we're talking about 2 million. So now we're going from thousands to millions to 20,000 for ultrasound. And this is the range at which we are actually performing these exams. And we'll talk about that range later too. How does this work? Well, you have an electrical current applied to these crystals called piezo crystals. These crystals are vibrating from that electrical current, and that creates these sound waves. The sound waves are transmitted through the tissue, and they reflect back once they hit the tissue. And that image is created based on that reflection, which is what your ultrasound image is. These are simple concepts when you know them, but if you don't, it's just like, oh, ultrasound chal raha hai, that's all. But when you actually understand them, you're like, yeah, this makes sense. The other second principle that is important is that whatever tissue that the wave will hit will actually give it some resistance. Based on that resistance and the nature of that tissue, you'll get some degree of reflection. Depending on the density of the tissue and the characteristics of the tissue, some waves will actually go through. So it's a combination of what comes back, what goes through, that gives you that signal. And your best signal is a 90-degree sort of back and forth, right? It's going straight at it and coming back. Anything that comes off at an angle is a distractor, basically. It's a refraction. Your wave is not going and coming back at you. It's like looking at the mirror. You're looking sideways, not straight on. So when your probe is not up against your tissue of interest perfectly, then you will get a more sort of inaccurate image. And so that's how you get artifacts. And we'll talk about artifacts, especially, everybody's talking about D1. Ironically, D1 was my easiest station to learn. Where I struggled was D2. So I'm surprised people say D1, but D1 actually I found the easiest, and I find the easiest to do and the hardest to teach somehow. Because for me it's very easy, but for trainees it tends to be difficult. But we'll talk about these in case, and it's actually fun to teach and for people to understand those concepts. Okay, so next concept you need to know about is scatter. This is important for what goes on with these waves. So imagine you're putting all these waves through. Look at this image. Some will go across, some will bounce back. This is all expected. But some will bounce off and go in different directions, and that's your scatter. And different compositions will have different tissues. So fat has a lot of scatter. That's why fat is bright on ultrasound, because there's a lot of scatter from fat. More solid tissue, like a mass with less fat, will have less scatter, so you have a much clearer image. Air is 100% scatter. All your ultrasound is getting scattered, therefore it's just like a bright noise that you see. And then fluid, on the other end of the spectrum, is allowing all those waves to go through, so there's no scatter. So that's why you get a nice black image on ultrasound, right? So this is an important concept to understand, and varying degrees of scatter determine the echotexture of your tissue. The other concept is how is the ultrasound wave being turned into an image, right? We think of these as waves normally. Sound is a sound wave, and that's called an A mode. Basically, when you have any kind of wave that is transmitted, it's a waveform like this. But what we're doing, the machine is doing for us, is it's converting that wave into brightness. So it's determined, this is all like human intelligence at its best, Allah's creation, best creation, working its magic to create this for us. This is why we're, by the way, the best creation, right? So they've decided, okay, well, we need to convert this signal into an image. So let's convert it into degrees of brightness. And that is what we see. So when we talk about B mode, this is the beauty of education. I didn't know what B mode is till I prepared this talk for the first course that I did in Karachi. Right? We just say B mode, right? Like, who knows what B mode is? This is simple. It's for brightness. So that's what B mode stands for. Okay? All these things, for those of you who are doing ultrasound and have like 100 plus, you already have been exposed to these things, so you know this. The other thing is what happens. So when your transducer is moving around, which is, the other thing is this is not ERCP. You go from ERCP, which is a very static field, to EUS, which is a very dynamic field. Your probe can't be just sitting there. I mean, obviously, if you're intervening or biopsying, that's one thing. But when you're studying something, your probe is constantly moving. But what happens is, imagine that this B mode, this transducer is going across this field. You'll see you'll come across different things. They will create these sound waves that are converted into these bright images that will show up on your display. And as you move across, they'll sort of start at the periphery and then come into view, and then you go off in the periphery. So these are concepts of the transducer moving across. The other important thing is the gain function, which I'll show you here too, but gain is essentially the strength of your ultrasound signal. So if your image is not very clean, you're not seeing it very well, you may have to increase the strength on your ultrasound signal. That's your gain. And the easiest way to know about gain on the bigger consoles is the largest dial on the right lower corner. And we have two different setups. I think we have the big console today that you'll see, the Ariata, right? And then you have the ME2 from Olympus. Oh, 3 and 2. 3, they're ahead of us because we have not used 3. So we'll learn the 3 along with you guys, but we have the 2. And so basically the gain on the big machines usually is a dial. On these MEs, it's going to be a button. I'll show you. But the point of this is that you can adjust the gain. You think of it this way, like your main focus you can adjust, and then you can do fine tuning of your focus. And that's, depending on the machine, you can call it, it's known as STC, spatial time compensation, or time gain compensation. And what it is along the depth of your image, at different levels of depth, you can adjust your gain. You usually have this like slight slant to the right, but if one area seems like there's a problem, you can adjust it based on the depth of your image on the screen. And we'll show you that when we do this. But the point is that you can do main focus, and then you can do fine focus to get your image. So why does frequency matter? And the best way to think of it is this way. If you have two things, one behind the other, you have very large waves. That one wave is going to try and capture both these things, right? And so they'll show up as one item, which is very sort of blurry. But when you say, okay, I'm going to make these very tight waves, then these tight waves are going to look at these two things, and they're going to bounce back separate, showing them to be separate. So the higher your frequency, the clearer the higher your resolution. You get much better resolution with higher frequency. The problem is, with such a high frequency, it's like putting a lot of energy into it. You put a lot of energy, you get a lot more out of it, but you fatigue faster. So what happens is you lose your depth of penetrance. So for submucosal lesions that are small lesions or something close to the probe, high frequency is good. But if you want to have depth, you want to look at something in the liver, for instance, you can't do 20 megahertz because you won't get the quality of image that you want at 20 megahertz in the liver. For that, you have to drop down to 7.5. Just for basic principles, most EUS is done at 7, the default setting is 7.5 megahertz. You can go up to 10, but for anything higher, you have to have mini probes. They're small probes that go much faster, and then they can give you higher frequency. We don't use those very much, but those are things that you need to at least be aware of these principles. Lateral resolution, on the other hand, like one thing that is next to another, that is more a function of the machine and how it's being designed and the setup. You don't have to think about that too much. You don't really adjust that. That the machine is taking care of, so you don't have to worry about things that are next to each other. The other important concept here is Doppler. So we're talking about like head-on, which is nice, but when something is moving, say blood flow, what happens is these waves will actually come at different frequencies at the probe. And those frequencies and movement are actually best appreciated not at 90 degrees, but anything other than 90 degrees. So the more the angle, the more obvious it is. So Doppler flow usually is best seen when something is not perpendicular to you, but actually at a side. So you can think, or you can see an image, and you think it's a bile duct or a cyst because you're right on top of it. But actually it may be a vessel, and because you're right on top of it, you may not appreciate that there's flow in there. That's usually with smaller things. For larger things, it's pretty obvious because there's turbulence inside in the flow as well. Okay, so moving on to the equipment. As I said, you'll see two different setups, a bigger console. This is an outdated image, I apologize. But something similar, the Ariata, which is the machine that you'll be using with the Fuji scope. And then the EUS ME2 or ME3, which is like a standalone box that connects with the with your regular Olympus equipment. So you can have it on a cart, which you'll see here, where you have the scope light processor and the EUS machine all on one cart, and then you can have the image on top. And then you'll have these different buttons. I'll be honest, there's so much that can be done with ultrasound that we don't actually use, because what our application is very limited. But I think there are ways to enhance even what we do if we knew more about this machine. But if you don't know, you can't really improve on it. So it's good to know, get to know these things. And the way that it works best for us in our setup is simply having the rep from the company come. Olympus, for instance, has these ultrasound experts, and they come, they spend time, they go over all these buttons. You remember like 5% of that, you forget the rest of it, and then you have to keep calling them back. You know, this is how learning works. You're shaking your head. Yahan pe it's not what.
When we bought our
Mm-hmm.
we were struggling because the problem is that the guys here at Zero, they actually didn't put it together properly.
Yeah.
We were here last
I remember, yeah.
And so we had to do online.
Yeah.
When I went to AEG Development, I said, look, I have
Yes.
going through everything. Like you said, by the time I reached Karachi, most of it was gone.
Yeah, you forget.
So now you need to have that
Reinforced, exactly.
That unfortunately is a big problem.
But you know, as we
have the reps don't know anything.
But maybe we can work with the Fuji reps there and figure out a way that we can do it either as a recording, so certain aspects that should be, you know, just get them recorded so you have an online access to that. So we can work on that. Okay, but basics that you need to know, the freeze button. Okay, this is basically putting your ultrasound on and off. So if you freeze your image, it's a still image. If you unfreeze it, then you can look at it. So to measure things, usually you want to freeze it so it's not a moving target. To study it, sometimes you want to freeze it. Or to take pictures. Dr. Hassan and I are very particular about nice images for our trainees. We really hammer this in their heads. You know, your report is a reflection of your sort of the importance that you give to quality and perfection. So if you have a report which has blurry images that make no sense, it just shows what's a priority for you. If in that moment your priority is your patient, then you need to do the best you can, and that includes getting the best image possible, right? These are first principles of medicine. This is not rocket science. तस्वीर ले ली भाई चलो अगले स्टेशन पे चलें बाइल डक्ट ढूंढें. And the other thing that becomes, sometimes it works flip, that they're too focused on getting a picture but not actually looking at the image. So there's a steep learning curve in this. You have to start with understanding what you're looking at, and then your next step is making sure you take a good picture for the purposes of documentation and reporting. So anyway, you can freeze and unfreeze. The next one is the depth. You can change how big or small something looks by using the depth button. These are terrible images. I really apologize. I need to improve on this for next time, Sadbhai. Sorry about this. But there's a plus and a minus. They never used to be this fuzzy. I don't know what happened, but I need to maybe no. But this is look at this. I mean, usually you can read these. Maybe it's the resolution. Okay. But yeah, but I'll update some of these for next time. But anyway, you'll see all these. Then the gain button, which is like, the brightness to increase your strength of the signal. So you'll see all these. In fact, this is me just giving you a list that you'll forget. But then the STC function, then there's a setting, and then you go to that, and you can do the STC contrast, etc. So you can adjust things. It's just like photography, right? You can adjust your things to get a final good image. But some principles, too much gain will make your image too bright. That means there's too much signal that you're transmitting. And too low gain will make it too dark. So you have to find that balance. And some of it's personal. You have to, your eyes get used to looking at what works for you, and so you may adjust it accordingly. And then similarly, high frequency, you may, basically it makes it a bit more crisper, and then you can fine tune it more with the STC, depending on, what's interesting is, for me, this image is actually optimized. But for them, it was like this in this textbook that they published. But anyway, your eyes get used to what works best for you. So you can change your frequency. There's a function for frequency adjustment too. On the bigger consoles, it's right on the console. On these ones, you have to like make a selection, like main menu, and then you select frequency, and then you can adjust your frequency. Your default nowadays is 7.5. So you don't usually need to change your frequency. And then you have other ways to, like in a radial, you can like look at full image, or you can split the image. There's so much there. One other important aspect is flow. So if you're looking at maybe a vessel or a duct, you can, or a cyst, you put flow on, and then there are different types of flow modes that you can go through to look at these things. These are important to a degree. There's a function on the bigger machine called eFlow. That's the one I prefer to use. Color flow will show you direction. So red is towards the probe, blue is away from the probe. Power flow is a much stronger flow, which is not really color determined. And H flow is like a mixture of these two, where it still shows directionality, but it's not as strong as power flow. Sometimes when you're not sure, you may want to go with color flow, because they'll give you the strongest signal. But bottom line is, you have various options. The more options that you have, the more confusing you can get. The other important thing is, sometimes the gain on the flow needs to be adjusted. So you may see that there's no blood flow, but it's actually because the strength is too low, so you may have to increase the gain. So if you're in doubt, always you can increase the gain, make sure that's a true low zero flow situation and not a false zero flow situation. So these things we'll go over as we go through these. I won't belabor this. PW, pulse wave. Yeah. So the other thing you can look at, once you have the flow, you want to see if it's an artery or a vein. Are you looking at a portal vein or a hepatic vein? Once you have the flow on, this option comes up, which is the PW, and then you can do the power wave, and you can actually see the waveform. So you can have an arterial waveform, a venous waveform, or a portovenous waveform, based on the power flow button. So that's a good feature to look at veins or vessels in the liver, for instance. Okay, I'm going to skip this. This is an important feature, like just to know about that the caliper is what you use to measure things. And we'll show you turn it on, you put it on one thing, you hit set, then you put the second one, and that measures it. And if you get it wrong, you can always delete it and start all over. So these are our little features on the console keyboard that you need to know about. Now moving on to the scopes. Nothing has changed with the Olympus scopes for like 10 years, so this is pretty relevant. But look at the difference in the scopes. This is an EGD scope, this is a radial scope, and this is your linear scope. Okay, these two are linear, and I just show like side view versus head on. And the camera on the EGD scope is right at the tip here. Okay, on the radial, it's set back further, and similar to the linear. The radial is a 360-degree ultrasound image, whereas the linear is about 140, I think, depending on the brand, but it's about 140 degrees. Your endoscopic image is about 2 centimeters behind your probe. So this is important to know about, especially for people who are just starting out, that what you're looking at endoscopically is not exactly where your ultrasound probe is. And secondly, when you're advancing the scope, especially through the mouth into the esophagus, that's important, as well as in the GE junction area, so any tight areas, and then the bulb into second portion. Other concepts to know about are the degrees of flexion. So this is an EGD scope. This is an older scope. I don't know if anything's changed here, but 9.8 millimeters on the Olympus. The radial, you can see the degree of flexion is much less. On the radial and the linear, it'll be a lot more. But secondly, knowing the not just the tip diameter, which is like 11.8 or 12.6 on the linear, but actually the overall diameter, the maximal diameter. So this is all good for like getting to a point, but this, your stricture should be able to, or your narrowing should be able to accommodate this diameter. Otherwise, the tip will get in and you'll push forward and you'll perforate. Okay, so it's important to know this number more than this, but you need to know both, of course. And this is similar both for Fuji. I think Fuji is 14.5, so there's like a minimal difference. So 12.6, but the number that really matters is 14.6. So you have to understand that the straight portion as well as sort of the viewing of camera and the angulation of the scope. This used to be the old Pentex. They called it the Widowmaker because it could perforate and could basically be really dangerous. So Pentex has moved on and their scope is much rounded like this now, but this is the Olympus. And so this is just to show this, when it used to be like this, it used to be more challenging. And then all this information is available online. And these charts are available and you should know about them and you should look them up. And if in doubt, if you have a stricter type of a situation, look at that information. Or if you have a child, just know these numbers to have a sense for what you're going to accomplish and encounter. Okay, this one I think is perhaps the most useful in terms of practical things. Knowing your dials and knowing the terminology. It's really important that we all speak the same language. So the terms that we will use may include big wheel up, which is thumb down or big wheel towards you, or big wheel down, which is thumb away from you. And if you look at the scopes, you have up, the U with the arrow towards you. So that's big wheel up, which is flexion. And so they're actually labeled like this. And D down, which is basically the arrow going towards you. So this is on all the scopes, by the way. So you have up, down. This is important, and we'll be using these terms a fair amount, obviously, in your training. And then also, don't forget that the ultrasound scope also has the left-right. So people get very focused on just up, down, but sometimes you have to do fine adjustment with the probe left and right. Especially when you're sampling, sometimes your needle is not in view, and if you do slight left, slight right, you can actually make the needle come into view in certain situations. Unfortunately, these are like upside down, but then when you look at the other thing is fluidity of movement is key. You have to give yourself space, and your arm and your elbow has to be really lax and relaxed. And of course, when we're all starting out, we tend to be tense. And we're frozen, and that makes it really hard for the scope movement to occur. But as you relax, what I want you to see is what's going on with the probe here. So you can see how the probe movement is so much nicer and smoother with these, relaxed movements, as opposed to if you're tense, what happens is you're holding the tip too tight, or you're doing these sharp turns, and the tip of the scope does not move so much. So you have to be really relaxed, try and keep the scope straight, and that allows you to have nice, smooth movements, and for you to be able to see your image of interest. The other thing is, similar to an ERCP scope, there is an elevator which allows you to change the angle of the device that you're putting through, and the elevator will help you obviously with sampling if you need to, or getting into the right plane. So that's something to know about. And the other thing is stabilizing scope. This is where Dr. Hassan and I differ slightly. I tend to like to lock sometimes and then do my FNA. I think most of the time you don't lock, but we just have different, unless it's like it's a tight situation. I just, especially with trainees, I have them lock it because I find that allows them to not worry about the scope moving back. And I'd say most of the time I do it too, maybe just because I find it easier. And that's the other thing, like in anything else in life, you eventually do what works best for you. Both him and I, do a pretty reasonable job with the EUS FNA. But our approaches are different. And actually you'll see a lot of how we do EUS is slightly different, but we both look at the same organs and we identify the same structures. It's just how you prefer to do it. But for me, I think locking and then using the elevator tends to work well, especially with trainees. So you can lock it, and then you can use your elevator up and down sometimes to help you. Um, so that's, I guess that was my last slide. So that's essentially it. Any questions? Yes, so it helps in the sense that sometimes because if if this is the stomach and this is your probe up against it, sometimes when you let go of your big wheel, it may move away. So by putting it up against it and locking it, it stays in place, and then your needle can come out against the gastric wall. But you also have your thumb on the elevator and big wheel together where you can do it without locking it too. And that's perhaps how Dr. Hassan does it without locking it. But it's just sometimes to maintain that tip position, the probe position in one place. But as I said, it's not like a you must lock or you mustn't lock. It's very variable based on the situation.
So one thing is like when you're going to lock it, if you pull the big wheel towards you and you lock it, you get in a really good position, and your needle is not even through that. That would be a problem in locking. So when you are going to lock after you put the needle into the scope. Otherwise, needle gives you a trouble getting through the scope, because if it's bent like that, that sheath is going to have a trouble getting through that part of the scope. So what he meant by lock is once you have the needle through that,
yeah, then you can
and then you get into the position, then lock it if it's unstable position. And sometimes we do things. I may think I'm not locking, but based on unstable position, I just like without even thinking. It's like riding a bicycle or driving. You don't think when you're driving majority of the time, and but you just lock it because it felt like it's unstable.
Yeah.
But the one point is like don't lock it before you get the sheet through the scope.
Yeah. It depends on your level of suspicion, right? So if you think that this makes sense for it to be, say, a bile duct or pancreatic duct, then you don't need to. But if you're in doubt, because especially with the pancreatic duct in the body, you have a small vessel that looks just like a pancreatic duct, and it's people can often get fooled because they're pushing so hard on the pancreas that they're compressing the pancreatic duct, and they're watching the vessel below it and assuming that's the case. So it's not that you have to, but if you're about to sample something and you want to make sure that you're not about to go through a vessel, it's good to change it.
Sometimes when you put just the probe on it, and it's all red, and that happens. So that's a lot of gain.
Yes, too much flow gain. Yeah.
When you increase the gain, other times you have to
decrease the gain.
There's so much in it.
Yeah, to reduce the noise. Basically, it allows you to reduce the noise. So then only the true vessel with the flow will have that Doppler image, and the tissue around it, you'll get rid of the noise, as Dr. Hassan said.
And other thing is like, especially the training. I think when you're in the process of learning EUS, you get hung up on these small things and miss the major things. So the goal today is not like we do not need to name every single capillary, give it a name, okay? Or every single blood flow we see, you don't need to give it a name, and it does not need to have a name. What main thing you need to do is, this is aorta, this is celiac, this is SMA, major branches, okay? This is SMV, the stuff like that. We're going to pay attention to the pancreas. I'll talk a little bit about the station, organ-based, and then Mustafa and I both will demonstrate our ways of doing. And we are different. We have learned a different way, and you will see that difference. But goal is, again, to do a complete EUS examination, take a look at the organs, get the job done safely and effectively. But whichever way you get to it, that should be fine. So don't get distracted by small things. That's what I'm saying, okay? Don't keep asking, "Oh, what is that small vessel at like 6 o'clock or like 3 o'clock, which is in the corner?" I have no clue what that is. So maybe one of the blood vessels. Okay?
The structure artery wall will be thicker, and we'll show you that when we do these cases. Veins tend to be thinner wall, and then the portal vein, for instance, the liver has a white rim around it. So that's something that you pick up, but the wall is another way to look at it. But smaller vessels, you can't really tell. It's more so in bigger vessels. You can tell the wall. Anything else?
Obviously, different structures differently. So you're looking at static arteries with tortuous course, right? See, the vein is coming straight, so depend on which kind of structure you're looking at. And that's maybe the one we're differentiating.
A lot of times, the wall is doing the same thing. And you start getting a sense of this shouldn't be the way, this should be the other way, vice versa. Or especially that vessel differentiation of the body. A lot of people will start to know this is the PD. The fellows will often say, well, there's a PD. Now it's put the dog out. Put the dog out. So the vessel. And then all I have to say is now relax your rate because they're compressing. But the cold is here. You're pushing down against the neck as you compress it. That's all it is. Relax your cold. And now you stop compressing the.
So I guess the key theme here is the balance. For Dopplers, you gain too bright, you reduce that, so you have less bright when you can see it. Likewise, that pressure thing is, air is the enemy. So you want to have as little air as possible. But therefore, you don't want you would want to maintain a contact and have a good coupling with the mucosa. But in doing so, you at the same time you don't want to cause too much of a compression, and as a result, you reduce the caliber of whatever ductal structure you're seeing it, and you can just compromise your views, EUS views, which is what the aim is, to have an optimized image to be able to interpret the anatomy and pathology.